Are we live, Karan? Sure. Okay. One second.
Recording in progress.
So, very good evening, everyone, and we welcome you all. So before we move on to our session, we recently lost Dr. Ajay Paul. I would request Dr. Karan to just take over and from YOSI, just convey the condolences. Over to you, Dr. Karan.
So from in the entire team of YOSI, we would like to give our condolences to the entire family of Dr. Ajay Paul, including one of our executive members, Dr. Anujit Paul, whose father had a very untimely and a shocking death. It was we were actually bamboozled, all of us, when we got to know about this. So we would like to honor him in this meeting and pray for his family. Can we observe about 30 seconds, or sorry, 15 seconds of silence before we go ahead? Yes. Over to you, Nupur.
So moving on with the YOSI Journal Club session, December. So the very idea of Journal Club arises from the the famous saying, "Publish or perish." Um, so um, Before we move on, we have the team YOSI by President Dr. Sonal Kalia, obviously Secretary Karan, who've been the key factors in the entire YOSI Journal Club sessions and have been providing an unending support. Very dynamic YOSI team. We have the very dynamic YOSI executive team. The concept of the YOSI Journal Club came from, for a young ophthalmologist, when they're in different stages of their career as a postgraduate, 1, 2, with respect to the thesis, they have a lot of questions. Okay, so as they move on from their PG to their fellowship to their practice, so to help these certain problems, to help reading between the line, understanding these statistics, we came out with this concept of a YOSI Journal Club. Journal Club is basically assessing the research literature, dissecting the article, how do you define a problem, analyze the article in the MARI format. So the format of the YOSI Journal Club is basically, there's a presenter, basically generally a postgraduate student or a fellow, who presents the article under the mentorship of a monthly mentor. It is moderated by one of the Journal Club team members. We have a research expert on board who has a good knowledge on the statistical and also gives the statistical critique. And then we have clinical experts or panelists pertaining to that topic who give the their take on the article and how it is relevant in our clinical practice. So the main crux of the journal article dissection, the acronym, the MARI format, which is analyzing the article with respect to method, assignment, assessment, results, interpretation, extrapolation. It is a step-by-step approach to reading the medical evidence. So as Dr. Pragya the presenter today will present, you will come to know about what the MARI format is all about. So this is, with this in mind, we have come up with a team, YOSI Journal Club. Me being the part, and yes, Dr. Anujit, who's been a very integral part of the team, followed by Dr. Rohit Modi, Dr. Bharat, and our mentors, Dr. Sabyasachi and Dr. Vivek. So the Journal Club team has been a brainchild of Dr. Sonal Kalia. I must thank her for giving us all the opportunity. And she was the one who started the whole sessions, and we are following her footsteps. So this is how we started. We floated a Google form, floated it all across in people who are interested in presenting. You may also email your interest to the official email ID of the Journal Club as mentioned. So we started way back in 2021. We had discussion on different articles, glaucoma, endophthalmitis, cataract surgery, ocular oncology, and pediatric ophthalmology. We came back in July 2022, had discussion on again various specialties, oculoplasty, glaucoma, on pediatric ophthalmology, retina. We had a very interesting journal club discussion on a refractive article, and today we are moving forward with a cornea article. So the article for today is a very interesting article, which is the eyes comparing DSEC and DMEC in cases of treatment of Fuchs corneal dystrophy, which is published in American Journal of Ophthalmology with an impact factor of 5.258. So the research expert for today is Dr. Shraddha Surekha, who's also a very, very dear friend. She's a cornea, cataract, and refractive surgeon at Centra Clinic, Mumbai. The expert panel, we have very young, dynamic young ophthalmologists and cornea surgeons on Dr. Chirag, the medical director at Amgen Eye and Child Care, Dr. Karan Bhatia, who's also the YOSI General Secretary. He's the cornea, cataract, and anterior segment and refractive surgeon at Manaktala Eye and Maternity Home, Meerut, UP, and Drishti Eye Foundation, Meerut. Dr. Aditya Pradhan, who's a consultant cornea and external diseases and cataract surgeon at Disha Eye Hospitals. Then we have the monthly mentor for this session is Dr. Bharat Gurnani, again a very young, dynamic, young researcher who's a consultant cataract, cornea, external disease, trauma, ocular surface and refractive services at Dr. Om Prakash Eye Institute, Amritsar, Punjab, India. And speaker today is Dr. Pragya Ahuja, who's currently a third-year postgraduate student at the AMU. And I must thank Dr. Pragya for taking up this opportunity and presenting today. And I'm the moderator, Dr. Nupur. I'm an anterior segment oculoplasty surgeon at Eye Care Eye Hospital, Noida. So with this, let's begin. Over to you, Dr. Pragya, for your presentation.
Thank you, ma'am. So good evening. I'll be sharing my slides now. Are my slides visible?
Yes, Pragya, please go ahead.
So I'll be discussing this article, long-term outcomes in fellow eyes comparing DSEC and DMEC for the treatment of Fuchs endothelial dystrophy. Starting with the session, first we'll ask some questions to see the awareness. What are the names of some endothelial dystrophy?
Just a second, Pragya. So we have this audience quiz. So Pragya will be asking the question. Those who wish to answer can just unmute and give the answers. And there'll be a set of 5 to 6 questions. A person with the maximum number of answers will be awarding a certificate of appreciation. So yeah, Pragya, please go ahead.
The first question is, what are some endothelial dystrophies?
Anybody wants to, or if you wish, you can just put it in the chat box. It's open to all. It's even the panelists can, I do see Dr. Dipti Chauhan trying to unmute herself. Okay, I think Pragya, just move ahead. Okay.
Yes. Yeah. Some endothelial dystrophies are Fuchs endothelial dystrophy, congenital hereditary endothelial dystrophy called CHED, and posterior polymorphous endothelial dystrophy. Is there any difference between the presentation of these dystrophies based on age, which may help in diagnosing the patient? Anyone?
Anyone from? Yeah.
So the answer is Fuchs generally presents in the 5th to 7th decade, while congenital hereditary endothelial dystrophy and PPD generally present in neonate to infant period. So the history, the age of presentation of the patient might help in diagnosing. So which endothelial dystrophy is generally associated with sensory neural hearing loss?
Congenital type?
Yeah, it is CHED is generally a part of Hartmann syndrome, which has sensory neural hearing deafness along with corneal opacification. Basically, there is a SLC4A11 mutation, which is characteristic of CHED, which is expressed not only in the corneal endothelial cell but also in the fibroblast and the stria vascularis of the inner ear, both of which have a neural crest origin. So they are seen together in this syndrome.
Who answered that?
Ma'am,
Okay. Was that Prakriti? No, Nusrat.
Prakriti.
Okay, Prakriti.
In which endothelial dystrophy does the endothelium stain positive for cytokeratins, which is generally a stain for epithelium? The
Go ahead, Prakriti.
The answer is posterior polymorphous corneal dystrophy, where there is epithelialization of the corneal endothelial layer. So the epithelium, like endothelial layers in PPMD, are generally pleomorphic, multi-layered with positive staining for cytokeratin, and they have multiple microvilli on their surfaces. So first beginning with the presentation today, first I'll discuss what is Fuchs and hereditary endothelial dystrophy. It is generally a bilateral corneal endothelial dystrophy presenting in 5 to 7 decade. It is generally autosomal dominant, presenting in females more than males, about 3 to 4 times more. This is the characteristic image of Fuchs. What does it show?
Corneal we can see loss of endothelial cells in the right eye.
Yes, the guttae are seen in both eyes. They are more prominent in the right eye compared to the left eye in the specular microscopy image. So, classification of Fuchs hereditary endothelial dystrophy is this is the old classification, which is based on generally the presenting symptoms of the patient. Nowadays, the ASOCT based classifications have come up. In this clinical classification, in first stage, the patient has asymptomatic corneal gut data. In stage 2, there is complaint of morning blur with stromal edema, which clears over the day. In stage 3, epithelial bullae are present, which are painful, and the patient sometimes may make bullous keratopathy. And in stage 4, there is subepithelial fibrosis, neovascularization. The pain, which is more prominent in stage 3, generally decreases by stage 4. The available treatment options for Fuchs are medical treatment, where we have to manage the corneal edema. So we'll give hypertonic solution or ointment 5% plus the intraocular pressure lowering. If the patient develops painful erosions, then we have to give bandage contact lenses for ruptured cornea. We might have to do an anterior stromal rupture or put conjunctival flaps. Keeping in mind, because we have to lower the IOP, which IOP drug, which anti-glaucoma drug is generally is to be avoided in a Fuchs patient. The answer is topical carbonic anhydrase inhibitors are generally to be avoided in Fuchs patient, as there is risk of irreversible corneal edema due to their usage. So the surgical options which are available for Fuchs dystrophy, the penetrating keratoplasty, DSEC, and DMEG. So in this study, we are basically concentrating on this surgical management and the comparison between them in Fuchs diagnosed in Fuchs patients. So coming to the article, basically endothelial keratoplasty.
Just to interrupt, you should add a PDEC portion there also, even though I don't do it, but you should add PDEC also in this.
Okay.
What is the difference between PDEC and DMEC?
I don't know.
Are you telling about DSEC, DMEC? What is it in the aage jaake?
No, sir.
Okay, so basically, if you look at this diagram over here, see DSEC, you take a little bit of the posterior stroma, and then there is and then the desmids and the endothelium. That is DSEC. Okay, in DMEC you have the desmids membrane, and then you have the endothelium, which is transplanted. In PDEC, which was developed by Dr. Amar Agarwal and his team, so there is the pre-desmids layer or the duas layer, and then you've got the desmids membrane, and then you've got the endothelium. The advantage of a PDEC is that you can use any age graft. In DMEC, you have to go for an elderly patient graft, ideally 60 and above or 50 and above. That is your donor cornea age that you use for case for DMEC. But because the stroma is, the stroma is the one that keeps the cornea into a whole position. If it's a younger age, this graft, which you fold it like a round or like a double scroll configuration that we call it, that DMEC will not unroll if you take a young donor cornea. The PDEC does not have that disadvantage. One thing, and then the dissection of DMEC and PDEC, the donor dissection is completely different. So in DMEC, you have to you have to do a blunt refine, and it's endothelial side up that you define. You take out the thing. For marking, you go opposite, but generally it is most of the procedure is done endothelial side up. For PDEC, you have to create a big bubble as you would do in a case of DALC and then do it. Okay, that is the basic difference between a PDEC and a DMEC, which can be asked in your exams also. So, please, any comments from Aditya and Chirag sir for the same, or we'll move ahead? I think let's go ahead. Chalo. Okay.
I'll be discussing the article now. Endothelial keratoplasty has the advantage over penetrating keratoplasty as it has more rehabilitation and predictable refractive outcome with no suture-related complications and less graft rejection. It has largely replaced penetrating keratoplasty for Fuchs corneal endothelial dystrophy. Over the years, endothelial keratoplasty has evolved. In 1956, Charles Tillett came up with posterior lamellar surgery, which was modified in 1999 by Jared Mills, who called it posterior lamellar keratoplasty, which was further modified to DLEC by Mark Terry and small incision DLEC by Jared Mills. PLK versus DLEC studies have shown that although both produce optically clear corneas, but the best post-op, best corrected visual acuity generally remain between 20 by 40 to 20 by 50. Then in 2005, Jared Mills came up with DSEC, which is Descemet stripping endothelial keratoplasty, which was called a refractively neutral corneal transplant by Frank Price. Mark Goraway gave the Descemet stripping automated endothelial keratoplasty, and Jared Mills gave DMEC. This DSEC was further validated by Prince and Chen and Associates in their respective articles. So the rationale of this study was to compare the best corrected visual acuity between DSEC and DMEC in a 5-year follow-up, the time taken to achieve this best corrected visual acuity, and third, the preference of the eye of the patient, that is the DSEC versus the DMEC eye, the subjective visual perception of the patient. In this study design, it was a 2-center retrospective case series fellow eye study, which was recruited subjects where the subjects operated from 2010 to 2018 were recruited for the study. The surgeries were performed by 2 surgeons, Robert W. Wiesenthal and David D. Verdier. A sample size of 128 eyes of 64 patients were used. It was basically a fellow eye study. The procedure was DSEC was the initial procedure that was performed in all eyes, followed by DMEC, and there was no dropout. The inclusion criteria was already diagnosed cases of Fuchs were included in the study, and all those eyes with at least 5-year follow-up in the DSEC eye were included. Exclusion criteria, all DSEC and DMEC cases that were done at these centers for conditions other than Fuchs were excluded. As a part of preoperative workup, they took the patient particulars, recorded the best corrected visual acuity in Snellen chart and converted it to logMAR. The eye to be operated was noted, any associated ocular comorbidities, and an ASOCT was done at both clinics preoperatively. At each visit, the slit lamp examination and intraocular pressure reading was taken, and refraction was only started after 1 month of follow-up, and then subsequently at every visit, the uncorrected and best corrected visual acuity was recorded. This visual acuity was then converted to logMAR from Snellen chart for statistical purposes. Each patient was asked in which eye they preferred after giving the best corrected visual acuity correction on the Snellen chart. By one surgeon, they did ASOCT on every follow-up to monitor the lenticule thickness in DSEC eyes. Excellent SPSS were used for statistical analysis, and the threshold of significance of P less than 0.05 was taken as significant. The surgeries performed, both of the surgeries, DSEC and DMEC, were performed under retrobulbar anesthesia. Routine steps of surgery were done for both these surgeries, and post-surgery, the patient was asked to lie supine with a pressure patch for 1 hour. After 1 hour, the patient was asked to sit on the slit lamp to adjust the graft position, and tobramycin or dexamethasone a drop was instilled, and the light pressure patch was again applied. On discharge orders, the patient was discharged on Tobradex QID for 1 week and was then changed to Predford 1% solution, initially QID and tapered to OD over a period of 1 year. Some eyes triple procedure was also done, which was phaco followed by DSEC or DMEC, phaco with IOL implantation. The results of the surgery in this study, DMAC was done in 29 eyes. DMAC with phaco IL was done in 35 eyes. DSEC was done in 39 eyes, and DSEC with phaco was done in 31 eyes. The mean age of patients recruited for this study was about 70 years. There were 40 females and 20 males, and no intraoperative complication was reported during the study. The DMAC eyes, mostly DMAC eyes were the left eye, and the DSEC eye was done in the right eye. Combined extraction of DMAC was 35 and DSEC was 31, as discussed before. In the DMAC versus DSEC comparison, the days to achieve best corrected visual acuity was significantly less in DMAC compared to DSEC, and the average follow-up time which was required by the patient to achieve this was significantly less, that is 3.6 years in DMAC compared to 6.7 years in DSEC. There was no difference in the best post-op visual acuity gain. It was not significant. The patient preference of the procedure, that is patient reference of the procedure, it was not significant, as 25 patients actually reported no difference between the two operated eyes. The donor lenticule thickness was monitored on ASOCT. The pre-op DSEC values were available for both clinics, which was about 137 microns in one clinic and 139 in the other. While in the post-op DSEC, only one clinic was monitoring the actual lenticule thickness over time, and they noted an average of 12 micron thickness decrease. So first I'll be discussing non-fellow eye studies that have been done for DSEC versus DMAC. These are mainly 6-month studies, and one Drautas in 2016 did a 12-month study. They reported similar findings with the similar best corrected visual acuity gain. Chamberlain in 2019, they actually reported a difference where they said that DMAC had 1.4 lines, the DMAC patients read 1.4 lines better than an ultra-thin DSEC patient. They used an ultra-thin donor, which was about 73 microns. Kurji in 2019 used a nano-thin donor cornea for DSEC, about 41 microns, and they reported comparable results between DSEC and DMAC. Dunker in 2020, they used an ultra-thin DSEC donor cornea of 101 microns, and they reported similar visual outcomes. In Matsau, in 2020, they used micro-thin corneas of about 63 microns, and they also calculated the vision-related quality of life, which was comparable in their study, in both the patients.
Just for the audience, I just want to say that an ultra-thin donor is less than 100 microns, and a nano-thin is less than 50 microns when you implant it. Yes, that's going to shrink over time, but that is the time of the implantation. Please go ahead. Micro-thin, I am not aware about. Anybody else? Chirag sir? Aditya?
No, micro-thin is not an accepted nomenclature. At least I have not come.
Even I am hearing for the first time, actually.
It's ultra-thin and nano-thin.
Nano-thin, yeah.
Yes.
Okay. Go ahead, please. Yeah.
Yes. So in fellow eye studies, these are also only 12 and 6-month studies respectively, where the patient have preferred the DMAC eye over the DSEC eye, especially except in the study in 2015 by Meyer, who reported where major patients reported no preference between the DMAC and the DSEC eye, which is similar to what our study reported. Wiesenthal in 2020, this is a study which has a time period comparable to the study we are discussing. They had a follow-up about 60 months in the DSEC eyes, and they did not report any significant preference of the patient of DSEC versus DMAC, and they used a donor lenticule thickness of about 127 microns, which is similar to the donor lenticule thickness used in this study of about 133 microns. In this study, DMAC took less. In the study that we're discussing, DMAC took lesser time to achieve best corrected visual acuity, and DMAC and DSEC had comparable visual outcomes, which has been seen in most of the studies that I discussed before. So there was this study which was conducted by Konstantinos in 2016, where they use matched pairs and between DSEC and DMAC, and they they used 50 eyes, and they said that there is a statistically significant difference between the visual outcomes of DMAC versus DSEC at all points during the first year of follow-up, which will be seen because DSEC is taking more time to achieve the best corrected visual acuity compared to DMAC. The donor lenticule thickness of ASOCT as was monitored in one clinic. In this study, they reported a 12 micron thinning in this study, which was also has been reported in previous studies by Anna Mater in 2018 and Jean-Parc Perron in 2019. In this study, they have used 133 micron thickness donor cornea. The best corrected visual acuity persistently improves in DSEC, and which has been reported in various studies by Madi S in 2019, who used ultra thin DSEC in 354 eyes. They not only included Fuchs, but they also used included patients with aphakic bullous keratopathy, failed grafts, hepatic endothelitis, ophthalmos, and the best corrected visual acuity improvement was seen over a 5-year follow-up, where 96% of patients in this study improved to more than 20/40. Best corrected visual acuity, corneal backscatter, and optical aberration have been seen to improve over 5 years in DSEC eyes in a study by Biebel et al. In 2000, which was published in Cornea in 2020. In DMAC, in a study by Weicker et al. Of 500 cases, 80% patients regained visual acuity of 20/25 in a 36-month period follow-up, of which 54% were 20/20. This study was conducted in 2016. These findings are similar to ours in the study that we are discussing. Higher order aberrations have been are reported less with DMAC, although this parameter has not been included in our study. But in the discussion, other studies have been quoted where a significant improvement in significantly less higher order aberrations are seen with DMAC compared to DSEC. In complicated eyes, which were not in, there was no specific mention of any complicated eye included in our study, but in previous glaucoma surgery, in an eye with previous glaucoma surgery over a 4-year follow-up, DMAC and DSEC gave similar rates of primary bubbling, endothelial cell loss, intraocular pressure was high, and there was high rejection rate. Post-op visual outcome was seen better with DMAC than DSEC in these previous glaucoma surgery eyes. In patients with failed PK at 6-month follow-up, best corrected visual acuity was seen better in DMAC, but they had reported more detachments and graft failures. In anaretic aphakic and patients with pars plana vitrectomy, where pars plana infusion had been done, these patients reported high graft detachment or failure more with DMAC, but the visual outcome was, however, seen better with DMAC. So in the study, authors have commented on the strengths of this study, where it's, according to them, it is a long follow-up study, which we have seen that only one study could compare to the 60-month follow-up that this study has taken. Larger sample size for a fellow eye study have been included in this as all the eligible patients were recruited. As per the authors, in the limitation of the study, only one center was performing the ASOCT scans, so only a proportion of patients were followed up. Patient satisfaction assessment was done based on subjective assessment of the patient by giving them best corrected visual acuity. There was no standard quality of life scales that were used for this assessment. According to the authors, they used an average corneal thickness of 133 microns. They comment that ultra thin DSEC might have given better and comparable outcomes with DMAC. All the participants were included in the study according to the patient. According to the authors, they had no matching and no formal sample size calculation was done to calculate the samples. So concluding, for conclusion, some other strength that I could pick up was a good sample size, as has been previously reported. All the patients included in this study were recruited. There was no reported dropouts and no complications were reported as per the authors. In the limitations of the study, what I could think was it was a retrospective study, and 130 ultra thin DSEC might have given, and there is some spelling mistakes are there in the journal, where at one point the sample size has been reported at differently at 2 points and in different parts of the article. converted the vision from logmar to logmar from Snellen. Although there are chances of error and inaccuracy when the conversion is done to logmar from Snellen. As Snellen, basically we are seeing the line, while in logmar every alphabet or number has a numerical value. And in this study, all the eyes with DSEC followed by DMEC from 2010 to 2018 were included. So a 5-year follow-up was only ensured for DSEC eyes, while nothing has been reported for a DMEC eye. And the time interval between the two surgeries, after how much time of DSEC was the DMEC performed in the other eye, no such uniformity or comment is there in the study. So there might be a bias in the outcome. So conclusion, the take-home points from this article is there is a comparable level of best-corrected visual acuity and patient satisfaction in DSEC versus DMEC. DMEC eyes generally achieve best-corrected visual acuity sooner, and DSEC eyes generally improve over a longer period of time. So according to the article analysis, according to Mari, the study question is well-defined. No formal sample size calculation has been done. All the available cases are included. For well-defined study follow-up period of 5 years is there. It is a retrospective study, and the study design and RCT would have given better results. The DSEC eye was DSEC. The surgery performed was DSEC followed by DMEC. All patients in the database were included. Well-defined surgical techniques have been mentioned, and certain differences in the surgical approach of both the DSEC and DMEC have been highlighted well in the surgery. All patients diagnosed and operated for Fuchs from 20 to 2018 were included. For triple procedures, cataract grading has not been mentioned. So because the stage of cataract and phaco might influence the outcome, that has not been mentioned in the study. In the assessment, the measures of outcome are the time taken to achieve this best corrected visual acuity and the patient preference of which operated eye has to be taken. A follow-up period of 5 years is good compared to the other studies that have been done. Results, statistical tests seem appropriate to me. And in interpretation, DMEC has a better visual acuity, almost half the time taken to achieve best corrected, and comparable best corrected visual acuity outcomes are seen at the end result. And the patient satisfaction was comparable. There was no specific preference by a majority of the patients between DSEC and DMEC. Thank you.
Thank you, Dr. Pragya. That was a very well-presented journal article and extremely well mentored by Dr. Bharat. I congratulate you for an excellent presentation. Just a couple of points. I would have liked you to, so when you presented the conclusion, in the article, when you present the article presentation is in 2 parts. Okay, you're presenting the article and then you're analyzing it as Mari. So when you're writing the conclusion has to be as per the authors. Okay, so whatever points you mentioned, that this bias and that bias, I would have liked it if you put it in the Mari format. Okay, you did it, you analyze it well. No, it's very good. You analyze it well. But just for future, whoever will be watching this session on YouTube later or the audience, if you go step by step, it's more easier. That's what you want to drive in. That goes step by step. So that's how it is. You first present the article as per the authors. Okay, and then you go on to the Mari, which is your analysis of the article. So whatever conclusion you said, those were your conclusions. That could have probably gone into their respective headings. But you did a very good job. This is your first presentation. We're really proud of you. Excellent presentation. Thank you.
Thank you. Thank you, ma'am.
Yes. So now I would like to invite Dr. Shraddha, who's a research expert for today. She's a cornea and anterior segment surgeon based in Mumbai. She has done research in stem cell transplantation and keratoprostosis for corneal disorders. She has a lot of publications, presentations on national and international platforms. And currently she works as an anterior segment surgeon specializing in doing complex cataract surgeries, cornea and stem cell transplants, and refractive surgery in Mumbai. I invite you, Dr. Shraddha, to give your statistical critique of the article. Over to you, Dr. Shraddha. Shraddha, you need to unmute yourself.
Am I audible now?
Yes, you are. Please go ahead.
Okay. So thank you, Nupur. Dr. Pragya, excellent presentation, and you did a great job at a resident level. So this is fantastic. Now, I'm just going to I've shared my screen. Are the slides visible? Nupur, are the slides visible?
Yes, Shraddha. Yes,
okay.
Yes.
So let's try and look a little bit into how the study was designed and if we could have done something better with it. And let's start with the abstract. So one of the things which is mentioned is that the main outcomes measured were best spectacle corrected visual acuity and duration of time to achieve best spectacle corrected visual acuity as well as eye preference. Now, when you do a study, even a retrospective study, it is best to define one primary outcome measure and then have others as secondary outcome measures. Why is this important is that you are very, very specific about what exactly you're trying to do with that study. And when you have a primary outcome measure, you use that to calculate your sample size. Now, in retrospective studies, it may not be important to calculate the sample size, but we'll come to that later on, how you can use that part later on in your discussion to make the whole point of your retrospective study relevant. Now, again, it's a long-term follow-up. So that is a commendable thing of this article, that they had, as compared to other articles which have been published, a good follow-up. Now, let's come to the concept of repeated measures. They've used fellow eye, which is also quite, a unique thing. Now, when you use fellow eyes, you would think that the baseline characteristics would match and a lesser number of patients are needed to do the study. But you have to remember that, say, a patient had DSEC in a certain year, say 2015, and DMEC at 2019. So the baseline parameter, the age itself changes. Also, the eye condition would preoperatively be different in both the eyes. So that is something we need to factor in. And it is not exactly, that you are taking the same person in the same eye and you're doing different procedures on them and comparing. So that's something that we need to kind of keep in mind. Now, they've been a little, non-specific when you're describing it in text format. So again, very important when we are reading this article, that when you write an article, you have to be very, very particular and crisp and specific. Now, they've written the purpose of the study is to compare long-term outcome of DSEC versus DMEC. It would be better that you mention, you're comparing the long-term visual outcome of DSEC versus DMEC. So those things kind of make it very, very specific to the person who is reading that. Now, coming to the sample size, they've mentioned here that no sample size calculation was done. And in that, I also mentioned that it's important to define the primary outcome measure. This primary outcome measure, now you see the primary outcome measure as your best spectacle corrected visual acuity. Now, if you see the logMAR chart, your 2020 is 0. And your 2025 says 0.1. So if you define your primary outcome measure is going to be a best spectacle corrected visual acuity, and you take a difference of 0 to 0.1, that is a difference between 2020 in one group and 2025 in the other group, is going to be clinically significant, then you use that 0.1 difference to calculate your sample size. And I've read articles wherein the authors have used it nicely. In their retrospective study paper, they mentioned, okay, that if we would have done a prospective randomized control trial with this 0.1 difference, we would have had such a big sample size. And this disease is quite rare, so we will not get this big of a sample size. So this is the best thing for this disease and what we are trying to study. So if you have that kind of calculations and specificity, you can write it in your discussion, make your retrospective study become very, very important, stating that prospective will not be possible or will be very difficult to manage. So it's very important to focus on that. Now, let's come to the second aspect, which statistical test to use. First of all, look at the data. Is it a difference that we are trying to find between two groups or a correlation between two groups? Second, find out what kind of data you're dealing with. So this is a very, very important thing. Every data set that you try, your primary outcome measure, your secondary outcome measure, you see, is it numerical, is it categorical? Numerical means you can give a number, and categorical means you're giving this is good, this is better, or something like this is red and blue. So nominal in that categorical would be when you give named categories. This is blue, this is green, this is red. Ordinal would be when you give it an order. Say this is good, this is better, this is best. Then you have something, you can have numerical data, like your best spectacle corrected visual acuity, you get numerical data. Next thing, you analyze if your groups are 2 or more than 2. So in our case, we had 2 groups. Then you analyze whether the data is paired or unpaired. Now paired means before and after. So if you've given, say your sugar level was 100, after giving a drug, your sugar level is 80. So that becomes paired. And then unpaired is like our groups, 2 groups that we had. Also, you need to determine if your data is parametric or not. Now at this point, please pay attention. So you have numerical data that you've got, that is you've got best spectacle corrected visual acuity of 60 patients. Now, if you arrange them, if they follow a normal distribution curve, that is Gaussian curve, then it is known as parametric data. And if the distribution is not normal, or if one is not sure, it is better to use non-parametric tests. So what you can do, you can put your data through these tests, KS test or Shapiro-Wilk goodness of fit test, that tells you whether your data is parametric or not. Or we can use a basic thing, that standard deviation. If it is less than 1/3 of the mean, then there is a chance your data will be parametric. Now, if you look at this chart that they have given, you look at this point, post-operative best spectacle corrected visual acuity in logMAR. It is 0.09 with such a big standard deviation, which is clearly not less than 1/3 of the mean. And even in the DSEC group, it is not less than 1/3 of the mean. So this data that we have is numerical data, and it is non-parametric data that we are dealing with. Now, the authors have told that they've used paired two-tailed t-test, and they've used McNemar test. Now, let's look at a standard table which tells you which test you're supposed to use. And this is a very good article by Dr. B.K. Nayak in IGO, which I think everybody should read and kind of have it in their ready reckoner to follow. So if you have unpaired data, now I would assume that in this article, it was unpaired data because the 2 patients will not match in age at the time of surgery, or the 2 eye conditions will not be kind of preoperatively the same. So I am dealing with unpaired data, numerical data. I will use not parametric, I will use others, otherwise, that is as a non-parametric test, and use Mann-Whitney U-test or Wilcoxon rank sum test. So here they've used the paired t-test, which is clearly not justifiable. So they probably would have thought that because they are dealing with fellow eyes, that's why they'll go with paired data, but I don't think that should be done. And that's why probably they went with paired t-test, but they missed the point that their data is not parametric. So the interpretation of all your p-values kind of becomes, irrelevant when the correct statistical tests are not used. So this, I think this article in IGO by B.K. Nayak has been like my go-to for all JCs across my fellowship. And this is something that this chart is something you can blindly follow. Now, from this, we go on to the other speakers who will speak on the other aspects of the article. Thank you, Nupur.
Thank you, Shraddha. Your that table on the, we keep on saying blank statement statistical tests seem to be appropriate. I think you've just opened our eyes to, what we are dealing with. That was an excellent statistical critique of the article. Thank you, Shraddha. And next I'll invite Dr. 1 second. Just move on to the... Yeah, so next I'll invite Dr. Chirag, again, a very young dynamic surgeon, who's the medical director at AmVision Eye and Childcare, Delhi. He's done his cornea and anterior segment fellowship at LV Prasad Eye Institute. He was an ex-consultant at the Center for Sight. Dr. Chirag will speak on the positive aspects of the article. Over to you, Dr. Chirag.
Yeah. Thank you, Dr. Nupur and YOSI for having me in this session. And amazing, Dr. Pragya, for a great presentation. And really, it was really nicely summed up article and a thorough literature review. And it's amazing that you could do so well in third year of your residency. I can't imagine myself at this point of time. So, thank you, Shraddha, for opening our eyes to the statistical part of it. It's the most difficult part of any journal club thing. So speaking of the positive, the best strength of this article is specifically taking up Fuchs dystrophy as a cause of endothelial decompensation and not aligning it with any other type of decompensation etiologies like traumatic or any other thing, which could have sort of created biases in a manner which is very much difficult to statistically analyze. Also, I feel Fuchs endothelial dystrophy is the most benign form of dystrophy as compared to shed PPD, since the stroma is clear and we can evaluate the visual acuity as per directly in correlation with the outcome of the graft. Also, like in ICE syndrome, these kind of patients have a disfigured anterior chamber. So the intraop challenges are very much different, even with the same surgeon, in case of DMEC and DSEC both. And in that case, the ultimate outcome of a graft would definitely would be very different. And again, which will create a lot of biases and things that cannot be justified comparing vis-a-vis. So I think the authors did a great job collecting data of such a huge number of 128 eyes, and especially fellow eyes with a large follow-up of 5 years in DSEC. Also, my take-home message for the DMEC part is like there are a lot of studies which say that the visual acuity is much faster in DMEC as compared to DSEC, which is supported by this article as well. But the long-term follow-up, this article has a 3.5-year follow-up of DMEC patients, which shows that the even DMEC grafts, if done well, do survive almost similar to DSEC grafts. So, and the good point about DSEC that this article has brought up is the DSEC grafts continuously, they have a comparable visual acuity as compared to the DMEC. That's one. And secondly, over a period of time, we can see a thinning of the DSEC graft. So that should actually point upon the improved visual quality of the patients, as we are seeing the DMEC. They have not compared it vis-a-vis objectively with in terms of higher order abrasions and all. Probably they would be doing it in another article. But again, the absence of patient preference to a particular procedure, especially in a fellow eye. So the patient who has got DSEC in one eye and DMEC in one eye would be the best judge of a subjective appreciation of the vision quality, rather than all the diagnostic factors that we have. So that shows that even the DSEC performs reasonably well over a long period of time as compared to DMEC. So these are few positive points that I can take home from this article.
Thank you, Dr. Chirag, for this wonderful highlighting of the positive aspects of the article. Now, I would like to invite our next panelist, Dr. Karan Bhatia. 1 second, yeah. So Karan needs no introduction. He is the General Secretary, YOSI, the chairman of the ISM-ICS Bio chapters. He's done his Diploma of Ophthalmology from RIO Sitapur, DNB from Arvind Eye Fellowship in Cornea, Phacoemulsification Refractive Surgery from MM Joshi Eye Institute, Hubli. He's trained in corneal lamellar surgery under Dr. Rajesh Fogla, and he's trained in pediatric cornea by SightLife. He has numerous awards to his credit and academics. He's been very, very active in all sorts of academics. It's there on the screen for you all to see. So before further wasting, I invite Dr. Karan to share his take on the article with respect to the negative aspects of the article. Over to you, Dr. Karan.
Thank you, Nupur. So first, I would like to congratulate Dr. Pragya for a wonderful presentation. She's actually made my job quite easy because she's highlighted a lot of the negative points that were there. So just to add a few, and I'll just, so she had said that it's a retrospective study, a prospective or an RCT would have been a better thing. Cataract grading also she has mentioned in cases of what happens is cataract grading is not mentioned. So for cases of triple procedures, it can affect the physiological conditions have changed. Also, they have not mentioned, what the target refraction would be, because again, the visual outcome would be better. So in DSEC, we would target around 1 to 1.5 diopters of myopia. That wouldn't be the case of a DMEC. So again, not definitions of the primary outcome and the secondary outcome. Sample size has not been calculated. Again, the factor that what already Shraddha has discussed, the conversion from a Snellen's to a Logmar. One important thing is that, only OCT was there in one clinic post-operatively, so which is a very important thing to assess how the apposition of the graft is and how it is doing and what is the size of the graft. Even though they've said that the donor graft was 139 microns in the area where they have not done post-operative OCT. So they have usually taken microkeratome grafts. If I'm right, they have dissected the microkeratome. A microkeratome can have an error of around 15 to 20 microns. So it may not be 139. So, has it been measured with a pachymeter? So they should have probably told these, not so many negative points, but yes, these could have been said. A very important factor which I feel has been missed out is the specular microscopy, which could have been one of the secondary outcomes, and how you compare DSEC and DMEC. For the DMEC, they have taken a 5 mm, decimeter excess. Any reason for that? Generally, Aditya, you do what, 7 mm or an 8 mm for DMEC? What do you do?
Around 8 mm, yes.
Around 8 mm. That's what we do. So 5 mm for DMEC. What is the rationale for choosing that when the other side you've taken an 8 mm graft? Again, SICS was there. They have gone through both the procedures with a clear corneal incision, making it 5 millimeters. So why not an SICS tunnel was chosen in such a case? Then also there is a PI was done in DMEC. Now, one factor which I had a doubt was, would a PI done before and PI done intraoperatively, would it affect outcomes? And if it was done, how many days before was the PI done in such cases? The refractive error difference between the two eyes could have made a favorable outcome towards, one thing. Yes, the positive points have been explained very well, that, ultimately it gets there. But yes, there's a faster visual recovery with DMEC. We all do know that. One last point I would like to add is the reason that they have started with Tobradex, which is tobramycin and dexamethasone. Why was there a shift from after 1 week to a Predford when you're giving a dexamethasone? Why did not you start Predford from day one? So these are the points from my side.
Thank you, Dr. Karan, for highlighting those negative points so well. Thank you. And thank you for being on board as a panelist for our journal club. Next, I would like to invite Dr. Aditya Pradhan, another very young dynamic surgeon. So Dr. Aditya works at Desai Hospitals, and he's done his research fellowship at LVPI Hyderabad, and he's also done his fellowship under Dr. Samar Basak. He's done his GMB ophthalmology from Sankara Eye Center, Coimbatore. And he has done a lot of DSEC skill transfer workshop, and he's been recipient of a lot of awards, a Young Achiever Award at the ISCRIS Meet 2016. He was the finalist, I think, under the Apple Tree AIOC 20. He was finalist. He's also on reviewer board of a lot of the Cornea section for the Indian Journal of Ophthalmology and the Tamil Nadu Journal of Ophthalmology. He's also the in charge of academics for the Young Ophthalmology Society of India chapter at the West Bengal State chapter. So over to you, Dr. Aditya, to share your take on the article and discuss about the recent advances on the topic.
Yeah, thank you so much, Nupur. I'll just share there are just 2-3 slides here which I wanted to show. So thank you, YOSI, for this opportunity and including me as a panelist. So, and kudos to Dr. Pragya for an excellent overview of the article. It was very nicely discussed. So I'll just give a brief totality to the 2 articles which need to be included in the literature as well. I have no financial interest to disclose. So basically, this was in the American Journal of Ophthalmology published this year. We showed the effect of, the systemic review and meta-analysis on the efficacy of thin and ultra-thin DSEC. So that is basically thin DSEC and ultra-thin. So the thin was defined as less than 130 microns, and the ultra thin was defined as less than 100 microns. So they went through the different PubMed, the Cochrane library, the MBase, and the main post-operative outcome was obviously the visual acuity. Secondary outcomes studied in the different studies were PACI, endothelial counts, spherical equivalents, and rejection rate, rebubbling rate. So basically, they found out that whether it was a thin or ultra thin DSEC, both the groups achieved similar visual acuity, pachymetry, the endothelial cell count, and the rejection rate and the rebubbling rate, irrespective of the graft thickness. But the important point which they noted was if the graft thickness was above 100 microns, there was a hyperopic shift which was induced. So this is the factor which Karan has also pointed out in his discussion, that if you are doing a triple procedure with DSEC, you need to account for this hyperopic shift when you are doing your biometry. And the second article, which is again just recently, it's in print. So basically, it is again a systemic review and meta-analysis of the outcomes after DMEC versus ultra thin. So there's clearly mentioned it is DMEC versus ultra thin. So ultra thin, as we know, is less than 100 microns. So basically, the study groups were Fuchs and bullous keratopathy. And so they had 7 of the 163 studies which met the inclusion and the exclusion criteria. So basically, the conclusion was that the improvement in the best corrected visual acuity was higher after ultra thin than the conventional DSEC. The DMEC was still superior, we all know that, because of the thinness of the graft. But the complication rates which are important was comparable for both the surgeries, except for the higher rate of rebubbling after DMEC. So surgeons who are early in their learning curve need to keep this in mind. So, and just to make it more complete, and in the interest of time, I'll not go into details, but just a quick review. This is again published in April and September on the Review of Ophthalmology website. So whatever is new in the DMEC, including the different techniques for folding grafts, unfolding grafts, including the challenging young donors in which the graft is difficult to unscroll. So please go through these articles, those who are in the early learning curve of the DMEC. And maybe the future is not corneal transplantation, but cultured endothelial cell transplants, and which includes DSO as well. So this is these are 2 articles which I would recommend to keep yourself updated. But just as an overview, for especially my 2 cents, not on just the article, in which I feel the grading of the Fuchs could have been included, because there is a difference in the Fuchs which we see in India and at the stage at which the European and the Americans operated. So just any complaint of the mildest visual disturbance or glare caused by Gutte. So basically, they get operated even at 6.6, 6.9, especially after DMEC has entered the procedure. But we don't operate, neither do we see Fuchs patients so early into our clinics. Mostly it's at an advanced stage of bullous keratopathy. So the grading and staging, especially the Scheimpflug imaging, which has been given by Sanjay Patel's group. So I think that they should have included in the methodology, that at what stage it is and what they are operating at. So that is one lacune I could see. But just for the YOs who are doing endothelial keratoplasty at any stage of their careers, it's better not to run after different terminologies and the latest procedures which are coming into the literature. Do whatever you are comfortable with. As a thumb rule, we do agree that thinner the tissue, it is better, especially in DSEC. But that doesn't mean you should abandon your established mode of surgery and try something new and end up falling into some different complications. If you are doing DSEC, try and be self-sufficient. It's always better to cut your own tissue, that is manual DSEC. Tissue may not always be available. There is a huge cost of procurement of the pre-cut tissue from different eye banks. So if you are familiar with cutting your own tissue, you don't need to depend on anybody. No single EK procedure, be it DSEC or DMEC, is sufficient. It has to be on a case-to-case basis. We all know that DMEC in complex size is quite challenging, and sometimes DSEC works much better. So choose the right procedure in the right patient, and please respect the learning curve. Any surgery which you do in ophthalmology has a learning curve. Sometimes it is short, sometimes it is steep. But just because something newer has come into the terminology doesn't mean you have to just jump after maybe doing 1 or 2 cases, and so always respect the learning curve and never compromise on the patient safety. So with that, I'll stop sharing. Thank you so much.
Thank you, Dr. Aditya, for sharing those recent advances. Especially, I'm sure that the articles that you shared will be very helpful to all the people who will be watching the session. And your My 2 cents slide was very good with that take-home message of not compromising the safety of the patient. So that's how the journal article is supposed to be. You learn to read the article, analyze like Pragya did. You think about the positive aspects, negative aspects, see whether statistical tests have been appropriately applied. And as Dr. Aditya has said, it also how you extrapolate it into your clinical practice. See what suits you the best, not compromising the safety of the patient ever. So thank you. And now we move on to any audience question. We don't have much of an audience right now. I'm sure that people who watch it later can type on the YouTube. So I just have a question, being a non-cornea person, probably it's a very basic question. So the panelists and Shraddha and Bharat, so the kind of patients, Fuchs that we see here, so what would be your preferred choice, DMEC or DSEC? How do you sort of, decide on it? Can start with, I think Dr. Chirag can tell. So what would you do in your practice? What was your, so you're on mute. So you're on mute. You need to unmute yourself.
Sure. Yes, I'm sorry. So actually, as Dr. Aditya was mentioning, the most of the cases that we get, even with the Fuchs, they are not early Fuchs. They are with late decompensations. And in case of triple, so I am not too much into DMEC. I have done few. So these are the cases where I would like to do a DMEC. But if at all, it's an PBK, pseudophakic case, already a pseudophakic. It's not a DMEC triple. It's not a triple case. Then I usually prefer a DSEC, just because of the repeatability of the product in my hands, actually. So that is one thing. And most of the cases that we get are usually failed grafts or complicated surgeries and post-traumatic, post-corneal tear, aphakic eyes. So in these cases, anyways, DMAC is a challenge and DSEC is preferred. So that's why if I see the whole lot of cases that I do in a year, most of them are DSECs, turned out to be DSECs.
Yeah, and Shraddha, any?
So I would actually say the exact same thing what Dr. Chirag said, kind of weaving, just close by in fellowship. I think that would be what we have been taught by the same teachers, and that would be our preferred. I mean, I think Dr. Chirag summed it up for me.
And Karan and
Ditto. It's ditto. Same. I think, it's ditto. Yeah. Aditya?
Yeah, pretty much sensible, because as I mentioned in my 2 cent slide, whatever you do, you're comfortable in doing without taking any undue risk is the procedure to go. DMEC, as we all agree, has a steeper learning curve, especially in complex cases. And patients present quite late. Some of them are heavily vascularized corneas. As Chirag has said, they are failed grafts. So DMEC is not a good option in a post-keratoplasty patient, because the graft doesn't tend to either contour well to the failed graft with the higher rate of rebubbling. So might as well do something you're familiar with. So still, in my personal practice or in my clinic, the DSEC still have a higher rate of acceptance and ease of doing. Yes.
And also for people who are in private practice, the donor tissue age also matters. So what donor you've got, it depends also on the decision making. I have one question for the others also, that what is your take on Ripasodil and Etarsodil?
No.
Dr. Aditya is heavily shaking his head. Yeah.
That was your question also, Nupur?
No, I said Dr. Aditya is heavily shaking his head.
Yeah.
No, actually, we recently had an internal class in the hospital regarding the use of hypertonic saline and these newer agents which you are talking about, Ripasodil and Etarsodil, in basically either post-cataract corneal edema or bullous keratopathy of maybe it's Fuchs or PBK. So the conclusion, whatever, I was the presenter, so whatever literature I reviewed, really no, even in hypertonic saline, it's just a stopgap arrangement till you do a definitive procedure. Either the edema goes on its own, especially if it's a cataract surgery, the steroids are definitely a confounding factor. And I don't see any role of these agents, the rho kinase inhibitors, in at least post-cataract SKs. If you are talking about Fuchs, trying to prevent it from progressing, again, no concrete evidence in the literature that it would retard the rate of progression or try to reverse. Rather, especially in established BK, we all know that it causes honeycomb epitheliopathy. So that's a form of toxicity on the surface. So again, no role. The only possible practical role I would foresee in the use of rho kinase for cornea specialist is if you're dealing with the acute graft rejection and the patient is presented quite well in time. So apart from the usual protocol which you follow of steroids and maybe IVMP, there is maybe a possible role of ripasudil or netasudil in trying to migrate whatever cells may be left in the periphery and help in the healing of the endothelium. And the other added advantage, it also works as an anti-glaucoma agent, the IOP lowering agent. So maybe possibly this is a very narrow area where these agents can be used. But otherwise, not as I know the companies are promoting it like quite for, aapka SK chala jayega and, all those things, hard cataract mates working. But I don't think so, because is there anybody in this group who is solely giving these agents after cataract surgery? No. We are all giving steroids and other confounding agents. So we don't know what is helping the endothelium to heal. So not really. And these agents are quite expensive as well. So I don't see any use of, rampant use of these things. No.
Yeah, so one of the things that it helps is basically with buying time. Practically speaking, when you speak to one patient, if you kind of tell them that this medication can be used, and in studies it may have shown some benefit, initially on the first or second visit, if you tell them surgery, a lot of them get scared. So it helps to buy time in that regard. The patient tries to get confidence in you. So I know that's not what evidence is talking, but practically the patient kind of develops some amount of confidence in you that this doctor is trying with medications rather than just saying surgery. That's, some people, kind of have that kind of thought process.
Right. So there are no further questions. I will request our monthly mentor for the session. 1 second. Yeah. Dr. Bharat, Dr. Bharat has done his MBBS from AFMC, and he's completed his cornea and microsurgery fellowship from Arvind Eye Hospital, from where he also did DNB. He's a fellow, he's the FRCS fellow, and also the he's the member of National Academy of Medical Sciences. He has keen interest in research and publications and has over 250 publications in various national and international journals. He has written over 7 book chapters. He's an avid reviewer, has reviewed more than 400 manuscripts for various international journals. He's currently the associate editor for 12 journals at different journals. They're all there. So so happy to have you on board, Bharat, on the Journal Club team, and also as a monthly mentor. And I have seen you guiding Pragya through every step of the presentation during the trial run. So as much credit we are giving to Pragya for an excellent presentation, I would also want to give you credit for making her present so well and making her prepare so well. So I would like you to now summarize our entire discussion and why we chose the article. Over to you, Dr.
As most of the things have been discussed by the all seniors here, first of all, I'd like to thank the YOSI team to give me this opportunity. And Pragya was already very diligent and she made everything easy for me, I think I must say. So like all seniors have already jotted down or summed up very easily for everyone. But just to simplify the article, I must say, like, now this is the era of DSEC and DMAC, and it has taken over penetrating keratoplasty in most of the cases. But still, as our mentors taught, penetrating keratoplasty still remains the gold standard in complex cases, somewhere where you want to rely on a technique. So Tillett gave the terminology of posterior lamellar surgery in 1956. Then it nearly took around 50 years for the evolution of lamellar surgeries when DSEC and DMAC came into vogue around 1999 and 2000, when Garrett Maley's introduced this, and he started doing all this where in his National Institute of Innovative Technology in Netherlands, where he had this institute. So he's the pioneer, I must say, Maley's. And now, as we know, like all challenges have been discussed. Both surgeries have their own challenges, own advantages. DSEC, as already mentioned, is the preferred surgery in most of the cases, less learning curve, and preferred for complex cases like anaretic eyes or AFK, glaucomatous eyes, post-penetrating, post-pars plana vitrectomy, and post-graft rejection, and all these cases. DMAC, although there are a lot of studies coming up with DMAC, but still remains very technically challenging because the way the graft has been taken out and how the graft is handled, and you need a good case like a Fuchs dystrophy or a pseudophakic bullous keratopathy with less of vascularization and inflammation to get good outcome in these cases. DSEC initial results, as we see, the studies published by Price et al. And all, the results were not encouraging initially because there was a lot of cases with rebubbling. So they went into and they saw like what is causing all these. So they came to a conclusion that it is the interface fluid between the lenticule and the posterior surface, and which is causing most of the, which is not letting the graft adhere well. So they did these, and they removed the interface fluid with the sweeping motion with a spatula over the surface, and they started putting small stab incision to drain the fluid, and which improved the outcome in further studies. And this was a landmark, I must say. They gave the way or paved the way for reduction of complication. And then as experience have increased, the way of handling the graft, post-operative patient positionings, newer devices, newer techniques, surgeon skills have improved. So the outcomes have improved in DSEC. Then came the importance of DSEC, how DSEC came into work, because they were encountering fewer perforations with manual removal of the lenticule, and the lamellar interface was sometimes not smooth. Somewhere the lenticule is thicker, somewhere thinner. So they started with microkeratome assisted DSEC, which came into practice just to encounter this and surpass this issue. And comparing DMAC, because DMAC we know the basic, like detachment and endothelium is transplanted, so it gives a more perfect anatomical restoration. So that's how DMAC became popular. So comparing seeing the article, the discussion has been nicely summed up. They have extensively discussed everything, but the take-home message are like DMAC gives a better visual recovery, earlier visual recovery compared to DSEC. Although the long-term outcomes are comparable, the incidence of graft rebubbling is more in DMAC as per majority studies, and DSEC has been reported to have better outcome in complex cases and glaucoma cases and all. So all the importance of this study, why this study stands out, because it's a long-term follow-up, and there are only 3 studies in the literature which are comparing the fellow eyes. So that's how this study holds importance. So this is the take-home message from the article, that any study with a longer outcome would add evidence to the literature, and it can go to a big journal. That's how we can plan our studies in future, anyone. So and because all studies were giving the results like DMAC is giving a faster visual recovery compared to DSEC. So then came the concept of why not reduce the size of the lenticule in DSEC. So they came with the concept of ultra thin DSEC, micro thin, and nano thin, these concepts. So but as you see and see the meta-analysis, everything, the results are all comparable. None of the techniques, I must say, is better than DMAC. Although they have, one of the articles I think I quoted like DMAC is comparable outcome with nano DSEC, but the overall none of the DSEC techniques is superior to DMAC. And one of the important trial was Descent endothelial thickness comparison trial, the DETECT trial. They compared DSEC and DMAC, the ultra thin DSEC, but in that also they found that DMAC outcomes were superior and faster. So, and another thing which few studies have taken in consideration is higher order aberration, which this study could have taken to add to the literature. But overall, it's a very good article where majority things have been taken up, and it adds to the evidence of the Fuchs dystrophy with fellow eye comparison. So I just have these few points in my mind to just sum up. Thank you.
Yeah. Thank you, Dr. Bharat, for summarizing the entire discussion and the article so well, and giving that, thing that even though maybe there is not much to extrapolate from this article, but, it adds to the clinical evidence. So like what as a non-cornea person, what I can say that probably DSEC, when it just came into practice, it had a lot of problems. Then over time, people improved. So, this is the way forward. You introduce a new technique, you keep working on it. And that's all. These articles are important to add to the evidence so that people can look into it and further improvise on it. So you never know, maybe next year Journal Club will be discussing DMEC versus something. And then, you'll be saying that DMEC is a better technique, We prefer this technique more than the newer technique. So probably that's the thing. So with that, we come to the end of our session, and just a quick audience questions we're done with. So just a quick vote of thanks and certificate of presentation to an excellently presented article by Dr. Pragya. Excellent presentation, very confident. You did a good review of literature. Congratulations and thank you. Dr. Bharat for being the fantastic monthly mentor. Dr. Shraddha for bringing out the statistical analysis so well. Dr. Chirag sir for being, giving the positive aspects of the article. Dr. Karan for bringing out the negative aspects of the article. Dr. Aditya for his 2 cents and the recent advances. And we will be back. This was the last session of Journal Club 2022. We'll be back in 2023. And we promise to bring a lot more surprises. We'll be having a lot of master classes on statistics and, statistical difficulties, the YOS. Just keep watching for the updates on the YOSI groups. And thank you once again, everyone. And you can email your interest or any sort of feedback or what sort of sessions you would want to have on the email ID. And wishing everybody a very happy new year. So, and your certificates will be mailed to you soon. And thank you everyone. I'll just stop the live streaming once.
Let's take a picture first. We don't stop the live streaming. No,
Okay.
I want to ask Pragya a question. We should, take pictures like this. I think people understood why we want to take a picture like this. At least the 5 cornea surgeons have understood. Why do you want to take a picture like this?
I don't know.
Understand? Because this is to identify where the graft is. Okay. So this is always the fold takes place in the stromal side.
Yes.
So that is one of the things. If your marking is gone, this is how you identify it. Folds like this. That is why we should take a picture like this, today.
Sure. You want to take a picture like
Let's
this?
take a picture. Let's take a picture. Everybody, I think we can do that.
Rather, you'll be able to take.
How can I take? Let's take. I'll take with one hand. Chalo, theek hai.
Okay, you take. I'm bad at. Should I stop the live